Praveen, could you introduce Dr. Rohit?
I don't think anybody needs to introduce Rohit because they'll probably say welcome Rohit, and Rohit is going to be speaking about the reason why Contura probably scores over other forms of LASIK. Rohit, over to you.
Thank you, Praveen, and thank you, ma'am, and the RC, and all the panelists and dear friends watching this. This is a full 1 day session, but I will try to summarize it in 5 minutes, and then we can have a discussion with some financial interest. The entire Contura is basically driven from this concept. The concept about the curvature is not just only the curvature, it's not just astigmatism, it's a mix of a pie chart which mixes the higher and lower order aberrations. And this is not, I'm not talking about keratoconus, I'm talking about the normal patients. So how you correct this is different from how you correct this. And that's what the Contura is completely based on. And what we see when you look at a topography like this is a cylinder, epithelium, how your ablation pattern is, everything is completely hidden, which we don't see. Now, more and more as we keep moving on, we start looking at aberrations and what we need to correct from every aspect of it. The epithelial zernica and epithelial aberrations is totally taking up a major role now because it determines how your anterior and total is, and of course, how your lens is actually behaving to a certain accommodation. And for example, you can see that the epithelium itself contributes to some amount of astigmatism. So what I've done is I compiled some articles of our own work, which some of them are published and some of them are in review, on what Contura is different. These are all the groups, just to say it's safe. And you can see that the line of gain of lines, and this any machines will do. And you pick up any machines today in 2020, every machine can give this kind of a picture. And this is something good, but what is important is the depth of focus because it induces less Q value, minimal higher order aberration. Depth of focus was not something which was studied very extensively. And today, in today's context, let's start with today with lockdown or no lockdown. Depth of focus is probably the most important for a young refractive patient who wants to come to you because it's taken as guarantee that 99 point of us who do refractive surgeon get that 6 20 by 20 vision. Very, very difficult now to give you a less vision with the machines what we're using. But what is really the new factor is the depth of focus. And that's what we looked at it. And that depth of focus, what was make me the most important selling point of Contura today. How does all these concepts of depth of focus and all the quality of vision, of course, I'm not denying that there is a quality of vision. Chitra ma'am rightly said there is a different quality of vision with all these procedures. And more or less, I don't want to even debate on this. Every machine gives you the same thing. But one major selling point for me is we did the study and that's got published. We compared with many other platforms. And the paper will be online and it just tells you how important it is. How is this the real future is looking at all these factors. Now, most of the modern machines, including Contura, don't look at your epithelial profiling. And that epithelial profiling has to be built in the future generation of laser surgeries. Because in this case, you can see that this epithelium is in this kind of a cornea, which looks perfectly healthy, but you still have a close to 0.75 diopters of cylinder, which is contributing to your aberrations. And that aberration, it's contributing to a significant amount of coma and trefoil. And this is a very important factor. And we are not treating this, we are going deeper into it. It's a very important factor to be considered when you're planning a refractive surgery or Contura in the future, because these are all the few things which we'll probably go into it. And we now are assuming that everything which is in the aberration platform has to be knocked off. It's like we look at them as a culprit, a jail culprit, and everything has to be knocked. But
1 minute left.
I feel that these things are more like a commensals. A commensals, I call them the commensal aberration. We need aberration to have a proper health and depth of focus. So we started looking at which aberration needs to be looked at. Now all this looks at research, but in future, all these machines can be customized. You can knock off only ones you need and keep the ones you don't need to treat. And this, I think, would be the real future of customization. And this is something which is just, and this We just launched now. It's a new software, Oculus, and we have joined. It took 7 years to build it. A lot of biomechanics machine and future topography machine will have it. It is the first artificial intelligence-based mathematical modeling where you feed in the data. It will tell you you don't need to worry about your biomechanics parameters. It will tell you how much does your cornea get weaker by different surgeries, and you just had to click this. And now we are on a beta testing. Maybe next year it will be there in many of the. And this is going to be the real future of how contoura or epithelial modeling will be. So I just took a little bit insight into digress into what the future is, but what contoura is for me is a better control of aberration. I don't say that it clears aberration, it controls aberration better, depth of focus, and the future is going to be on the use of simulation on AI and use of epithelial maps. Thank you.
Thank you very much, Dr. Rohit. I know contoura cannot be discussed in 5 minutes. There's one question I have. Like, largely, we do contoura LASIK in a normal eye, wherein we feed in the subjective refraction and the subjective axis. Now, you have a patient, otherwise normal eye, with some higher order aberration from induced coma, and you would treat it by the topographic axis with the C4, C12 compensation. Can you promise the same refractive accuracy to these patients as you would if you were to do a normal contoura treatment?
Basically,
or would you promise them that you'll give them a better quality of vision, but there might be a small residual?
If you are going to go back into looking at the ablation pattern when you keep the refractive error as 0, and if your ablation pattern shows that the ablation is 8 to 10 microns without treating a refractive error, then I will tell, and I'm sure that this contoura will work very well for the patient. However, when you keep the ablation as 0, and you have only 2 or 3 microns of ablation for a 0 refractive error, that means the patient does not have any higher order aberration. And this is important because you are not going to do any benefit to this patient. Whether you do this, or of course you will do benefit because you are not going to induce anything. But contoura works very well in a patient who is normal but has higher level of aberrations which may induce some changes. But the most important point which I want to bring in here is, without understanding the epithelium, if you are doing a contoura treatment, then epithelial cylinder itself could mess up with your reading, because epithelial cylinders of 0.5 diopters or 0.7 diopters will not going to change even after you do your contoura. So there has to be a little bit of optical understanding of this, but still in a normal healthy patient, if you ask me why I want to do it, and this is something which is got published also in GRS, it's the depth of focus. And the depth of focus is what is very, very important for a young person who works in IT or any of this.
Rohit, I have some questions for you regarding depth of focus. Okay, depth of focus in a young patient, basically the corneal abrasions contributing, or correction of corneal abrasions contributing to depth of focus is very small. Maximum it may be like half a diopter or 1 diopter. But these patients have very good accommodation. They have like 9 diopters or so accommodation with the crystalline lens. So that itself gives a very good depth of focus. So how does this half a diopter or quarter diopter correction actually increase the depth of focus? Because depth of focus in young patients, again, is because of accommodation. So how much does it contribute? How can it make such a big difference is something which I'm wondering. The other question is, see, I have seen so many patients, because contoura basically is based on treating the topography and the cornea. But I believe that refractive surgery is correcting the refraction, be it with phakic IOLs, be it with LASIK, PRK, or with SMILE. And if the patient has 6/5 vision with glasses or contact lenses and is happy, then you just need to correct the refraction. And correcting the topography itself can alter the aberrations and induce some kind of a difference in the lower order aberrations when you correct the higher order aberrations. So it may be a little off and it may not be as accurate as correcting the refraction. That is my question. And then there are so many patients who have a corneal cylinder, but they do not accept cylindrical power because they have lenticular astigmatism, which counteracts the corneal astigmatism. And these patients, you do a topoliink correction, and then they will have residual astigmatism because of the lenticular astigmatism. And this was my question also to Canelopoulos, and somehow he said that it gets corrected over a period of time, but we want the patient to be reading 20/20 day one. So if the patient has lenticular astigmatism and corneal astigmatism, which are kind of correcting each other at opposite axes, then how do you manage it? I mean, how does Contura work in such cases? I mean, this is my question, because I believe refractive surgery is about correcting refraction. And of course, I would 100% agree if there is an abraded cornea. If there's an abraded cornea with corneal abrasions, keratoconus, where you actually have to treat the abrasions for a therapeutic reason, then topoliink corrections make sense. But for normal standard corneas, I think just correcting the refraction would do well. And if you look at phakic IOLs, where you're not treating the cornea itself, these patients are among the happiest because you're just correcting their refraction. And when you have a normal fitting, you always go, and if ready-made suits fit you very well, you can just go and pick it off the shop because you know what you're going to get. You know the results. When you get a bespoke tailoring, you don't know what you're going to. It may be good or it may be bad. So that's my whole kind of a logic. And I think this logic of using topoliink for normal cornea is a little warped.
I would answer your question from the last question you asked about the whole cylindrical. Absolutely, I agree with you. And because of the paucity of time, I did not include. There are a lot of software, third-party software. We also build one where you decide not to treat those patients who have a high lenticular astigmatism. I mean, because we know that I call it the group 3. There's one called 4 cities, and we have our own called a 3Z software. So you're right.
So you need to also have an eye trace to look at the internal abrasions, and just doing corneal topography and deciding to do a Contura would not help, right?
Absolutely. Because see, what happens is the group 3, which forms group 3 is the lenticular astigmatism being higher, forms 3% of your Contura patients. I mean, this is something which we publish, and 3% of them, if you put them in your bracket of Contura, they would not work. I mean, 4 cities with Dr. Amurthy uses gives a different platform. That's a different discussion. So you 100% agree on this. So in these patients, the total wavefront would do well, or just a simple aspheric treatment would do well. The first question is about the second.
Depth of focus.
Depth of focus. Depth of focus, optically, you have a different answer. In reality, you have a different answer. Optically, if I give you an answer, depth of focus, of course, it improves and all that. Younger the patient is. But where it really helps you, sir, is the patient who complains of end of the day fatigue. End of the day, and many times we blame it on the dry eye. We say that the patient comes to you that, and we took this sort of patients and started looking their depth of focus. And we believe that this patient should, they had a beautiful, you're right, 9 to 10 diopters of beautiful accommodation. We studied on Osiris. But the challenge was that poor depth of focus in them was creating. And the question is, does it happen to everybody? May not. So this depth of focus optically has a different definition compared to what it actually translates on the patient. But having a good depth of focus in different ways, patient may not recognize it, but it may just help them. For me, if you ask me where it really helps them, is being comfortable after 12 hours of working without having any fatigability is probably gives them that confidence. So
but that also depends upon binocular vision and fusion and stereopsis, because there was a study by Praveen Krishna where he compared LASIK and SMILE, and he found that the stereopsis and fusion is much better post SMILE than with LASIK. I think Praveen can also. So then probably the fatigue would be less, right? So there are multiple factors.
I'll probably chip in, but that wasn't Contura. That was wavefront guided LASIK with the older platform. But I think what is important also is for depth of focus is to have similar aberrations in both the eyes is what we found. Yeah. If you have different aberrations in both the eyes, then actually you have lesser stereopsis. And so your binocular performance at close as well as intermediate distance tends to go down. So I think maybe the fact that Contura probably corrects aberrations similarly in both eyes probably is what resulting in what Rohit is finding as well about having less fatigue and also the fact that the depth of focus is better.
I think I would like to just shift gears and make a comment. We have a galaxy of speakers here with a wide experience with various modalities of treatment. For me, it's a 20 happy patient who is more important than 2020. And with all these developments, PRK, control ASIC, SMILE, I do all of them. I know the positives and negatives like all of you do. But I often wonder whether my patient in 1997, when I started off with LASIK, was much worse off than what I'm finding in 2020. I had unhappy patients then, I have unhappy patients now. Of course, as far as the safety is concerned, understanding correct ectasia, dryness, etc. is concerned, we have progressed quite a bit and we hardly see any correct ectasia. But as far as run of the mill, a walk in the park case, a -3, -4 diopters, with all the different modalities that are available to us, with all the extra expense that we subject our patients to, has the happiness quotient increased? It's not only in my case, but I have not seen any big published study which says that the patient, refractive surgery patient in 2020 is happier than his counterpart in the year 2000. Comments?
I think what Dr. Ramamurthy is saying is absolutely correct. See, these are, I would say, these are when Zyoptics came in, we were among the first adapters to Zyoptics, and that was for Eagle Vision and 2014 or 2010 or whatever we were talking. And it was basically at that particular time, the aberrometers were not good. And I think it was garbage in, garbage out, in the sense that our Zyoptics patients were less happier than the plano scan of the Bausch and Lomb machine. I think Shiri and Ram would bear that. But all of us started talking about it because it was a marketing thing. And these are all things. See, actually, the best study would be one eye smile, the other eye contoura, and seeing the happiness quotient of a patient from a real life situation, as to from a real life situation, does he feel which eye is better? And I think Dr. Ramamurthy may bear us out, but I think they have done a study where I think 80 to 90%, or he may be able to tell, almost a very significant majority of the patients felt that the eye which had smile, they in real life situation, they felt better than that in that eye.
Yes, that's true.
Can I make a comment, Dr. Ramamurthy? I think it's also we are the culprits. We are putting these thoughts in the patient's mind. We are trying to educate, or not actually educating the patients, but confusing them into believing one is better than the other, and that plays a big role in the final expectations as well as the happiness quotient that they have. So we as doctors need to be more careful and also more responsible before we actually condemn or praise a technique.
Rupal, you're not clear. There's
Yeah.
some signal issue. So we didn't hear your question actually.
No, so I was just commenting that it is us who are at fault because we are increasing the expectation levels of the patients and we are misguiding them about one technique over the other, and that plays a big role in the final happiness quotient of a patient. And I think we all should be more responsible of what we talk and what we give to the patient in terms of education, the so-called education of the patient that we are doing. Also, Rohit, I wanted to ask you, doesn't the epithelium mold itself after any procedure that you do? So would it not matter whether you are going to do epithelial customization, even if you are able to do epithelial mapping, post-op, that epithelium is not going to remain the same. So then how are you going to customize that portion?
What I said was, if there is an epithelial irregularity, do not try to do any of this topo-guided treatment. You avoid it because you are not going to treat the epithelium, because once you put steroids for 2 weeks with the 2 weeks or whatever, and when you cut your nerves, you will completely change. If you're doing a smile, that epithelium might still remain the same because you are not taking, there's always going to be some hemostasis balance because you're not cut the nerves. But if you're doing a LASIK, then if there is an epithelial issue, then you would not do it. And probably if there is an epithelial change like that, you would probably do a smile surgery because you know there is a hidden ocular surface issue which is creating the epithelium to mess around there. So what I said is I'm not compensating the epithelium at all. I would not do a topo-guided treatment if I see an epithelial issue out there, because that epithelial compensation is completely missed in a lot of our custom guided treatment is what the point I wanted to drive home here.
There's one
Rohit, I would like you to answer this question in the sense that, we started Zyoptics almost together. You are really doing cutting edge refractive surgery today. Do you feel that your patients today are far more happier than what you found when you started off with your refractive surgery?
The question is, see, we are so scared to ask our patients how happy you are.
How happy you are.
I think the answer is,
We rather be in a bubble that, see, I believe that I'm in a bubble, assuming that whatever I'm doing is getting my patients very happy compared to what I did then. So I would rather be in a bubble and be in my la-la land so that,
no, one thing is definitely clear that we do understand a lot more than we did before, and we feel a lot more happier treating these patients, that we are better informed. Whether it translates to better visual outcome, we've not compared patients treated 10 years back with those who come now, because they were happy and these are also happy. One other question, Rohit. They say that in
1 second, Chitra.
I think they were equally happy earlier also, Chitra. Now also they are happy. Only thing is, I think in terms of
one of the good indicators is the incidence of retreatment. Has it gone down over that? So because the patient's unhappiness is also dependent on where you have got the patients as regards the refractive error and the outcomes. So at least over the years, Ram, I feel that the incidence of retreatment has gone down over the last couple of years. That is the only thing, because maybe the nomograms have become tighter. Maybe we are treating better from that perspective. Otherwise, I think the happiness factor is still the same.
our limits of treating refractive error has also gone down. Earlier we were treating higher amplitudes, but now we are not treating higher amplitudes. So that also will
We can choose the right modality for treating even extremes of refractive error. So each one has narrowed down.
I just want to add one point, if madam can permit, so I can then, the concept of treating all aberration is like concept of taking care of all bacteria in your ocular surface because it's a bacteria. I think this concept is something which I think has to change. And this concept, because of the optical work, I feel there are a lot in keratoconus patients. When you use adaptive optic to see how much of aberration, what to correct, you'll be surprised. Many of them want to keep the coma back. If you take the coma off, it's like a phoropter. Adaptive optic is like a phoropter. If patient actually vision drops, that's why when you put a contact lens, some patients actually drop the vision in their keratoconus. That means our understanding of mathematical optics is great, but our understanding on what optics happens on the patient is completely very, very poor. And this is exactly what I told Dr. Sriganesh sir, that mathematically depth of focus is doing well, but how much it translates in the patient on a day-to-day basis is completely different ballgame.
See, the brain also has a filter which filters out the higher order aberrations, be it coma or spherical aberration. There was also a study among Navy pilots who had 6:3 vision, and most of them had some amount of vertical coma. So it's not that all aberrations are bad, and some patients tolerate aberrations better than the others. So it is something which their brain is attuned to. So that is something which is very difficult to decipher, because we basically look at only the optical aspect and forget what is beyond the eyes. But vision is more than just the optics of the eye.
Those Navy pilots had a fair amount of spherical aberration also.
thank you.